I can, there we go. Okay, recording has been started, and we will leave time at the end for any questions that you have for any of our speakers, and you can always put your questions in the chat, and we will definitely get to them. So just really quickly about the Transplant Ambassador Program. Today is our first webinar of the year, and we're thrilled to cover this new topic of genetic kidney disease, which we think is really exciting and important for many patients. Next slide, please. Our Bob already did a great land acknowledgement, so we'll go past that. We'll go past that. So just a little bit about me. So I am the co-founder and the chair of the Transplant Ambassador Program. But this is a special topic for me because our family also has genetic kidney disease. It's a gene called MUC1, which was only identified in the last few years. So before that, many members of our family had kidney disease, but didn't know what it was, and we didn't know who in the family would be getting it. So now that's something that is has been clarified for us. So I'm really excited to do this topic, to talk about the advantages of understanding the genetic base of kidney disease. So I did receive a kidney transplant in, actually it's been 14 years. I put the wrong date. It was actually 2010 from a living non-related kidney donor who was my sister-in-law. We now know from the genetic testing that 2 of my 3 children, 3 daughters, have the gene. And so obviously it's a family legacy that we'll continue to manage. TAP was started in 2017 and with a goal of really making sure that no patients and donors had to go through this experience alone or without the benefit of having other patients and donors to talk to. And then just recently in the last year, we launched the Kidney Patient and Donor Alliance so that TAP would have a permanent place to live within a patient and donor-led organization. Next slide, please. We're all of us in the Transplant Ambassador Program. There are just over 200 of us now across Ontario, and we also have a program in Halifax. We are all kidney donors or transplant recipients who are currently living with a successful transplant, living or from a living or deceased donor. And our goal is to connect with patients at the earliest possible stages, as well as donors throughout their experience, and even after transplant, where we find lots of questions and concerns. Next slide, please. There's a lot of great peer support programs out there. Well, not a lot, but there's a few, and we really encourage you to take advantage of any of them that might be able to help you. There's a few differences about TAP. One is that we started out as a research project, actually based out of London, and then worked with the ORN to expand that across Ontario, the Ontario Renal Network. So because we started out as a research initiative, we have fairly strict privacy and confidentiality protocols. All of our ambassadors provide vulnerable sector police checks. We receive the majority of our referrals from the hospitals as we work in coordination with the hospitals. We also measure our impact. We measure how many conversations that we have at each of these hospitals, and then try to understand whether there's a correlation between those conversations and whether transplant rates are increasing at those hospitals. We also work hard to try to find the right match for patients and donors. We'll talk about that in a minute. You can also reach out to us directly through our Transplant Ambassador emails, which we provide during any exchange, and also are available on our website. And lastly, as I mentioned, we're an independent patient-led program. Next slide, please. So when I spoke about getting the right match, on our homepage, which is transplantambassadors.ca, in the top right-hand corner, there's a directory of all of our ambassadors. You can click on any of these tiles or a combination of these tiles. And so if you're looking to talk to a kidney transplant recipient who, let's just say, has PKD, you could click on both of those tiles, and you would find a list of ambassadors that are transplant recipients with PKD. Some of the people that you're going to hear from tonight will be on that list, and you can reach out to them. You can often also watch their videos online as well. So, so just know that there's very likely someone like you who you can connect with, and we're happy to make that connection for you as well if you don't see it on the directory. Next slide, please. We also launched a new platform on our website, something called Patient Seeking Donors. So if you are a patient looking for a kidney donor, you can post a little profile on our website. Next slide, please. What's unique about this website is that you actually don't have to provide any personal information. You don't have to give your email or phone number, or you can speak to your anybody that reaches out to you through our website, and only give them your information when you feel comfortable doing that. We've made a couple of connections already through our site, which has been up for about 15 months or so, and looking at providing more services for patients. So if you go to our patientseekingdonors.ca, you can fill out a profile for yourselves, or you can reach out to any of us and we can help you. Next slide, please. So this is tonight's webinar. It will be recorded. Someone just asked that in the chat. And also there will be a video of that recording. Once we get the recording and we edit it appropriately, it'll be up on the website, and I'll let everyone know that it's available and you can watch it there. Along with any of our past webinars that we've had, they're also all up on there. Next slide, please. I think that might be it. No, just a plug here for within the Kidney Patient and Donor Alliance, we work to grow and support TAP, but we also have an initiative called Transplant First. So that's we'll put that in the chat, but it's Transplant First with a 1 st.ca, and there we have a some information about how we're looking to increase, as a patient and donor group, advocating to increase transplant for all patients and make sure that more patients are able to get the optimal care, which we know is clearly transplant. So I believe that's the end of my slides, I think. Yep. So actually, we're not going into our top panel. We're going to make you wait for that. We're going to move next into our presentation from today's special guest, who is Dr. Dervla Connaughton, who is just an incredible expert in this area and a great resource for us. So over to you, Dervla. And if anyone does have any questions, please put them in the chat or wait until later in the webinar. Thank you. Thanks, Dervla.
Thank you so much. Can everybody hear me? Yeah, great. Well, listen, it's such an honor to come here this evening and chat to all. So I really appreciate the opportunity. And as Sue said, my name is Dervla Connaughton and I'm here in London. And if you have any questions, feel free to stop me along the way or chat, okay? So let me move my slides along. Oops. I'll get your faces out of the way. So as I said, the topic today is what's new in genetic kidney disease and transplantation, and what should every family with genetic CKD or chronic kidney disease know? Some disclosures, but none of them are actually relevant to my topics of discussion. And what I'm actually going to talk about is I'm just going to touch briefly on what I mean by genetic kidney disease, because there's a lot of terms out there and there's a lot of kind of information, but I kind of want to get just to chat about what we're talking about today. And then I want to talk the big questions is, how common is it? Should we, in who should we suspect it in? And this ties on to our next question on who should actually get genetic testing if you have kidney disease. I want to touch on some maybe the barriers to genetic testing, the largest, and I want to touch on the Genetic Non-Discrimination Act. And then I'll finish off, because it's TAP we're talking about tonight. We'll talk a little bit about genetic testing and kidney transplantation. So, what is genetic kidney disease, and what does that exactly mean for us in nephrology? So, as we probably all know, we all are different. We all have different genetic makeups, and that's usually made up of our DNA, or these strands of what I like to refer to as the recipe for your makeup. So we all have the DNA, and as I said, it acts as a recipe. And what happens is these strands of DNA are read, and that's the instructions to make the proteins, which are the building blocks of us, basically. Our DNA has regions that make proteins and regions that don't make proteins, and by and large, the regions that make proteins are called genes. So genetic kidney disease most often occurs when you just have a defect or a change, or what some people refer to as mutations, in your DNA, usually in the region of a gene that causes some type of kidney disease. And if you look at this at the micro level, what usually happens is you've a change in one of your bases, or a change in the reading frame, or how these instructions look. So it's like messing up the recipe or changing the recipe. And this change can ultimately lead to production of dysfunctional proteins, or potentially not producing a protein at all. And when this is needed by the kidney, then this causes problems and can ultimately lead to chronic kidney disease. So when we're talking about genetic kidney disease, I suppose the big question we generally get asked is, well, of all the people out there with chronic kidney disease, particularly those with end-stage kidney disease, how common is genetic kidney disease for these people? And overall, there's many studies out there, but generally the data now suggests that if you're sitting in a general nephrology clinic and meeting patients who have chronic kidney disease, we would expect that 1 in every 10, and potentially 1 in every 5, if we look at the more recent studies, may have a genetic type of kidney disease. If then we look for people who are more likely to have genetic kidney disease, the biggest factors, or what I call risk factors for genetic kidney disease, are things like having a family history of kidney disease. So that certainly increases up the likelihood that if you undergo genetic testing, you will find a genetic cause of kidney disease. And finally, there's certain criteria or certain subtypes of kidney disease that if we do the testing in it, we're much more likely to confirm that there is a genetic cause of kidney disease. And there's certain types of kidney disease among the realm of all types of chronic kidney disease that this is true for. So I'll go through some of this now. So I don't want to get into the nitty gritty of the data, but these are two big studies that looked at all these patients who have chronic kidney disease and tried to figure out, well, what proportion or what amount of these patients do have kidney disease and do have genetic kidney disease. And I'll just point out that this is data related to adults and not necessarily children. So what I'm talking about here are adults who come to the clinic with chronic kidney disease. So the first biggest study came out of Columbia University in New York, and a lady called Emily Groupman, and she looked at over 3,000 patients, all who had chronic kidney disease. Where these patients were recruited from, they were recruited actually for other studies. One group was recruited from the Aurora study, which looked at statin use in patients who had chronic kidney disease. And then they had a second group of patients who came to the Columbia University and all had end-stage kidney disease, usually between the ages of 50 and 80 years of age. So they did genetic testing in these over 3,000 patients, and what they found is almost 10%, 9.3% of them had a genetic type of kidney disease when they did genetic testing. There's certain kidney diseases that are certainly more common, and probably most people sitting here know or have heard of polycystic kidney disease. And when Emily looked in these populations, she certainly found that a lot of people had polycystic kidney disease. The next biggest group, and again, this might not come as a surprise, is that a lot of people in whom we found out had genetic kidney disease, a lot of them were due to Alports, and these are the collagen mutations here. Um, but what is important to note is that in this group of people who got a genetic diagnosis after genetic testing, often it was a change in a gene that was only seen once in the entire group of these 3,000 patients. So some of these forms of genetic kidney disease are quite rare individually, but overall they make up to this almost 10%. The next biggest study came out of the US as well, and this time what they really wanted to do is they really wanted to hone in on patients who were older. And by older, I mean they weren't childhood onset, or they weren't young in their 20s. These were people who developed kidney disease or developed end-stage kidney disease and had testing in their 50s. Now, as I get closer to that, I think 50 is young, but still, they said their average age of their cohort was about 55 years. And what they did is they did another type of genetic testing called gene panel testing, but they looked for about 300 of the different causes of genetic kidney disease. And this was across lots and lots of centers in the US. Some of them were academic centers, many were community hospitals, but they included over 1,600 patients. And what they found after genetic testing, that in fact 20% of all these patients who had chronic kidney disease, when you did the testing, you found out that they indeed had genetic kidney disease as the cause of their kidney disease. And what's also interesting by this group is a lot of these people didn't actually know they had genetic kidney disease before they had the testing. And in all the patients who they found out they had a genetic cause of kidney disease, almost 50% of them were a new diagnosis, or they were reclassified from the previous diagnosis. That is, they thought they had one type of kidney disease, they did the genetic testing, and they found out, well, actually, you have a different type of kidney disease. So that brings us to the next question. Well, who should have testing for genetic kidney disease? So there's a lot of work going on at this at the moment, because it's hard to say, well, listen, everybody who has chronic kidney disease needs genetic testing. I don't think that's what we're trying to say, but we're trying to hone in on the groups that would have the best likelihood of getting a diagnosis and who would benefit the most from this type of genetic testing. So as I said, there's a lot of groups, including ourselves, who are looking at this, but there's two ways really to kind of divide those who need genetic testing. You could first off look at those who have these so-called genetic risk factors. And as we spoke about earlier, family history is one of these big risk factors for genetic kidney disease. There is a concept of having kidney disease and having another type of disease. So this is what we call extrarenal features of disease. So you might have kidney disease, but you may also have liver disease. You have some other organ outside the kidneys involved, or you have multi-system disease. What we're seeing more and more from the studies is that these people are more likely to have a genetic form of kidney disease. I did touch on this age. When we started out these studies almost a decade ago, there certainly was, everybody was saying, listen, genetic kidney disease is a disease of young people in their 20s, maybe their 30s. But I hope I pointed out in the most recent studies, definitely that age that is younger is getting older. So now we're saying certainly less than 50 years, but I think more studies are probably needed. And I think the more we do, the more we find, well, genetics affects people regardless of the age. Your genes don't change over time. The other way to look at it is there's certain types of kidney disease that we know if we do the testing, well, they're more likely to find out that, yes, you do have genetic kidney disease. And some of these are listed here. So as I said, there's certain what we call patient characteristics that might point to you, yes, you need to do genetic testing. And as I said, I touched on these: family history, young age of onset, or extrarenal features. There's one type of kidney disease that is very dear to my heart, and I don't know whether I can call it a type of kidney disease, but many people have this entity called CKD of unknown cause, or they refer to it in Canada NYD, which I like because it says not yet diagnosed, which is a very optimistic term. But many people get different names for this disease. They might get familial nephritis or hereditary nephropathy, or a multitude of different names. But ultimately, it means you have a type of chronic kidney disease, but despite the testing, even doing kidney biopsy, we still don't know the cause of kidney disease. And as I said, that's a very dear cause to my heart, that we find out the cause of kidney disease in these patients, and particularly in these families, because I think genetic testing could play a real role in kind of figuring this out for people. The other thing not to lose sight of as we move forward in genetics is that there's some people who will benefit from having a genetic diagnosis because their treatment can be tailored for that. And I'll touch on that in a little bit. There's some people who need it for conception or pre-implantation counselling. And of course, there's this important emerging area that we might need to use genetics more and more in kidney transplantation, both for our recipients, but also for our donors. So with this in mind, the Provincial Genetics Program, I'm not too sure if many people are aware of this group, but basically it's run by Ontario Health, and its goal is really to determine across all medical specialties, you know, who should have genetic testing, what does that genetic testing strategy look like, and how should that testing be done. So this group started up almost a year ago now, and our first goal was to decide, well, listen, based on all these studies and based on all this data, who needs to have genetic testing for kidney disease? And that's the group that I'm currently working with. And the second step to that is to decide, well, yes, you've identified who needs genetic testing. What type of test do we need to do in these people? I won't go into detail, and as I said, this is in draft at the moment, but basically we've divided it into whether you know the cause of your kidney disease. If you do know the cause of your kidney disease before you head into testing, well, depending on what category category of disease you fall into as the primary cause of your kidney disease, there's certain tests that should be done based on what you look like in terms of your kidney disease. If you fall into this category of chronic kidney disease of unknown cause, certainly if you have a family history of kidney disease, if you have certain ages of onset, or if you have these extrarenal involvement, there's a different type of testing, a more comprehensive type of testing we should do. And we're hoping to provide full comprehensive guidelines so that everybody knows A, who should be tested, and B, what does that testing ultimately look like. So hopefully these will be available clinically before the end of the year. Probably one of the biggest questions I always get asked is, it's great getting a diagnosis, but what are the ultimate benefits of getting a diagnosis? And it is important that there is a benefit from any test that you do. And sometimes, particularly when you're heading into dialysis and transplantation, your focus, has to shift, and there's other priorities. But for me, finding a definitive diagnosis is usually the goal, and it's something I feel very strongly about, and I you know what I mean, I like helping these patients and families come to this diagnosis wherever possible. There are other benefits, though, other than just getting a diagnosis. For some people, and I touched on this, some of the genetic kidney diseases can occur with diseases that affect other organs. Maybe they affect the eyes, maybe they affect the ears. Some of these you may know about before you have testing, but some of them can be picked up after you have the genetic diagnosis. Sometimes you can pick up subtle features in the eyes that weren't really thought about before, but when you have the diagnosis, you have a bigger picture and you can actually find out these then. For some, and increasingly so, there's some treatment options, or there's a horizon of treatment options. And then genetics has come so far in 10, even 5 years. This opportunity to open up treatment options is particularly advantageous if you know the exact cause of your kidney disease. For others, knowing what the cause of their kidney disease and being able to counsel both them and their family is very important. So having access to genetic counseling has become a really important part of what we do in kidney genetics. And one of the main reasons is to know who in my family is at risk, and that's probably one of the most common questions I get asked. Well, I have kidney disease, but what is the risk for my loved ones, and how do I know for definite whether they're going to be affected or not? So these are usually the benefits of having a genetic diagnosis. I would say even 5 years ago when I was giving this talk, there was probably not much information on what the actual, hard, what we call clinical benefits are of having a diagnosis. And by that I mean, does it change what treatment you get in the here and now? But I think this is certainly changing. And this is the study that I talked about from the US that had these 1,600 older adults who had genetic kidney disease, and had genetic testing done. And what they interestingly found, and this was just published late last year, what this group found is in those that they confirmed a genetic cause of kidney disease, there was an actual change in the management plan in over 90% of those patients. Now, what do they mean by the change of management plan? This can be seen here in column A. And what they've done, which is quite interesting, is they divide the patients into those that had positive genetic testing results in red and negative genetic testing results in blue. So they said overall in those that had positive genetic testing results, 90% had a change in management, and that could be a change in their treatment plan, impacting family planning, referral to genetic counselling, or providing information for at-risk family members. But what's interesting is even those with negative genetic testing, there was some change in their management plan because of this. Panel B is probably the most important one that we look at from a clinical perspective. So what we're saying here is in patients who had a genetic diagnosis or indeed had a negative genetic test, was there change in the treatment that they were having, the medicines or the medications they were taking right now, or how their management of their kidney disease went forward? Did it change after they had their genetic testing results? And what they found is yes, 30% of those had a change in their treatment. This did vary. It depended on the type of kidney disease you had. So some types of kidney disease, when you confirm the genetic diagnosis, and many of them, up to 50% of them, had a change in the treatment plan. In those who had other types of kidney disease, 60% had a change in the management plan. But you can see in nearly every type of kidney disease that they studied, there was a change in management plan after you had a positive genetic result, and to a lesser extent, even when you had a negative genetic testing result. I don't work with Natera at all or anything, but the study was done by them, and they have some patient information on their website that they go through, but the actual genetic testing was done through their program, and that's why I put that picture up there. So I think there's going to be a big shift. It's, there's still a lot of work to be done, but it's very important to remember that now more than ever, there are some actionable genes. And what I mean by actionable genes is there's a change in how you manage the disease depending on the gene you find. It is hard to predict before you go into testing who you're going to find it in and what the gene is. Believe it or not, there's almost 600 kidney disease genes now. So I often say when people we're chatting in clinic, what those potential implications are will depend very much on what I find. It could be one of 600, but there is the potential. For example, there's certain diseases now that we know have a direct specific treatment. So be it Fabry's disease, there's a certain treatment for that if you find the gene that causes Fabry's disease. There's other ones, primary hyperoxaluria. There's certain types of protein leaking kidney disease due to changes in a gene called coenzyme Q10, that there's a medicine that you can take, a coenzyme Q10 replacement, that can actually slow down or even reverse the disease. So certainly there are some genes, if you find, you can target specific treatment plans. For others, even though there isn't a specific treatment for the disease or a cure for that disease, there are some treatments that you can institute that slow disease progression. So a primary example of that is if you find changes in genes that cause Alports. Certainly instituting what we call renoprotective strategies have been shown to slow the progression of disease over time. In some people who have kidney disease, they need immunosuppression therapy. They need to suppress their immune system. For others, that's not needed. And what we're finding more and more is if we figure out the exact gene cause, we can figure out who needs the immunosuppression therapy and probably more importantly, who doesn't need it. And certainly this will be a new area that we look into, doing genetic testing before you institute some of these immunosuppressive therapies to make sure you fit into the correct category that needs that treatment. In transplantation, there are some diseases, there are many diseases that don't recur, and that's very helpful information going into transplantation. There's also some diseases that do recur. And knowing whether your disease is likely to recur or not can give you valuable information on how you manage your medications in the post-transplant period. So knowing this before you go into transplant, is very important for some patients. And I also touched on this, that there's sometimes, because you have a certain genetic cause of kidney disease, you can screen or detect these extra renal or outside the kidney disease manifestations. For some, it could be diabetes. For some, it could be cranial aneurysms. For others, it's eye problems. And then certainly moving forward, there is genetic testing that we can offer for reproductive counsel, both prenatal and pre-implantation, which is very important. So this just really reiterates the same, depending on the disease that you think it is, and if you confirm the gene in question, there are exact treatments that you can institute that are beneficial in each of these types of diseases. It's not available for all diseases yet, but I do hope as time moves on, there'll be, as we understand the diseases, and more importantly, as we identify them, there'll be more and more treatments. Sue touched on this. There's a gene called MUC1 that causes a very specific type of kidney disease. And it was only through, so this is the MUC1 protein. So changes in this gene causes a defect in this protein so that it's not cleared from the cells, and it gets stuck in the kidney and it causes damage over time. And although we don't have a treatment yet, by understanding the disease and the gene and the protein, we now can develop targeted treatments that help actually clear this protein, this defective protein from the cell. And that's what I'm just showing here. So although this isn't, available yet for patients, what I'm trying to point out is knowing the disease and understanding it can lead to potential treatment targets, not just now, but also into the future. So this is an exciting part. But ultimately, for me, the most important is the patients and the families that I'm privileged to work with through their journey of finding. And many of these families I work with for years, because they undergo this thing called the diagnostic odyssey. And this is taken from the Rare Disease Organization, and it tracks the journey from start of symptoms for a patient to this long and arduous route of seeing specialists, and certainly for some kidney diseases where you have multiple systems involved or multiple organs involved, they can see multiple specialists and maybe never get a unifying diagnosis. But ultimately, this journey in any rare disease, but particularly in genetic disease and genetic kidney disease, can span, years, decades. What they say is, on average, these patients have 5+ years of investigations, and 50% never get a diagnosis. And I always show this family. This is the Murphy family from Ireland, and it was the very first family that I even recognized that could have a genetic cause of kidney disease. And we didn't know the cause of their kidney disease when we met them initially. And it became very important because of all these people in this picture, four of them had chronic kidney disease needing transplantation. And ultimately, this one brother here wanted to donate a kidney to his brother. But how do you allow this to proceed if you don't know the cause of kidney disease and you can't ultimately assess his own risk of kidney disease? But it was through genetic studies initially, genetic testing, and ultimately understanding the cause of kidney disease that allowed us to, first of all, figure out what was going on in this family, and second of all, allowed to screen multiple family members so that we could figure out who's at risk and ultimately who's not at risk. And the time is improving, the time to diagnosis, but it is still slow. I run a kidney genetics clinic here, and we've been going since 2020, which wasn't a good time to start, but still, we started in 2020, and we've just analyzed data on the first 300 patients seen, and believe it or not, that the average wait time from when they were first diagnosed with chronic kidney disease to actually getting a genetic assessment or genetic referral is 13.5 years, plus or minus 12. So that's the average time. So a very, very long time for many of these patients waiting for a genetic diagnosis. Even when they see us and we institute the testing does take a long time. So the average time for a genetic diagnosis after review is about 6 months, but depending on the complexity of the testing, and this can be longer, but at least this is months and not years. So that's a promising sign. Hopefully we'll get that down. And as I said, across Ontario and certainly actually across Canada, this is a strategy that many centres are taking to set up these dedicated kidney genetics clinics. Initially, a lot of this was run out of genetics. And sometimes now this is run out of nephrology. It probably doesn't matter. You just need to see someone who is either an expert in kidney and genetics or genetics and kidney, and that can institute the testing that is required. But here in London, we run the Kidney Genetics Clinic, and we have the expertise usually at a single visit to evaluate patients for genetic kidney disease. I think a very important part is to give patients access to genetic counselling, and we see both pediatric and adult patients. And as I said, this is just one strategy we're using in London, but I know there's clinics being set up in Toronto, some in Ottawa, and some in Hamilton. So it is an approach that we're trying to extend not only across Ontario but also across Canada to meet this need, given the evidence out there that genetic kidney disease occurs. Um, One of the things that always bothers me, I think I touched on this, is that, sometimes we have a diagnosis of a type of genetic kidney disease that is common. So if you want to touch base with a patient who's been through the same experience as you, you know, there's groups. So example of that is polycystic kidney disease or Alport's. Although it's not common in the general population, there are groups out there who you can connect with. But some of these genetic kidney disease are individually very, very rare. I showed you the data from the study that showed, in a third of the population who get a diagnosis, the gene is only seen once in the entire population. So, trying to connect and trying to gain an understanding of your subtype of genetic kidney disease can be hard, and often it can be isolating at the start when you get this diagnosis. So with Sue, we've tried to set up this kidney genetic website, and the hope is that it will provide a resource, where people can go and learn about genetic testing and genetic kidney disease, but B, as time moves on, that we have more and more supportive links for patients with the various different types of genetic kidney disease. And as I mentioned, there's 600 kidney disease genes, so there's many different subtypes of genetic kidney disease. So this is just the homepage here, what it looks like. And as I said, it hopes to give some useful information, but also useful links to groups like the Transplant Ambassador Program or the PKD Foundation. And I'm hoping over time that we will be able to extend these groups so that every person who gets a diagnosis of genetic kidney disease may have the opportunity to connect, to learn more about their individual type of genetic kidney disease, and ultimately to move the data forward, or move the research forward in their subtype of genetic kidney disease, so that ultimately we get treatments for these patients. I'll nearly at the end, but this is one of the biggest questions I get, so I always like to address it because I think it's a really important point, and it's a really important piece of information. And again, this is the type of information we're hoping that will be accessible on the website. So we are very lucky in Canada that we have very good and comprehensive laws to prevent genetic discrimination. And the Genetic Discrimination Act has been in place since 2017, and it was upheld by the Supreme Court in 2020. So, and basically what this states is that nobody in whom you enter into a contract with, and a contract could be employment, it could be insurance, it could be school, it could be a marriage, any contract you sign, nobody has the right to either ask you for genetic testing or to request the results of your genetic testing. So if you're applying for insurance, or if you're applying for health insurance or life insurance, nobody can ask you for the results, and nor do you have to disclose the results of any genetic testing you have had done. It doesn't protect you from a family history of kidney disease. So if they say, does mum, dad, brothers, sisters, you have to let them know about your family history. But the idea of this, it was to remove that barrier that people felt, well, if I have genetic testing done, I'll be discriminated against. So nobody can ever use your genetic testing results against you in anything, or it's punishable by law. A similar act does exist in the US, because we do have some movement between here. It's the GINA, so it's similar, although it does vary somewhat across the states. But the GINA is in place, and again, it prohibits genetic discrimination. So that's just an important piece to know about. And I'm just going to end on genetics in the transplant setting. And I think this will become more of a useful area, and it'll become an area that we'll have to think about a little bit more. At a provincial level, the renal genetics expert group that we're involved with are hoping, once we have the initial set of guidelines done on who needs genetic testing and what that genetic testing should look like, our next goal is to look at genetic testing specifically in the transplant setting. There is some data out here, and Christy Thomas has published this nice flow diagram, and I think this will probably form some of the basis of what we use to develop these guidelines. But basically, one of the areas we're looking at, and I think the example came up in the family that we mentioned earlier, is what do you do with someone who wants to donate a kidney and they have a positive family history of kidney disease? So again, we think that moving forward, genetic testing, rather than trying to exclude people from the donation process, we're hoping moving forward, particularly if kidney disease runs in your family, that we can hopefully in the future use genetic testing to try and exclude those family members who have no risk of kidney disease, and allow them to safely donate into the future. But this will be an area that we'll look at, and certainly as we come up with guidelines, or indeed if any of this group today want to give us feedback or help us with this, this is something we're going to be looking at, but I think it will be something that will be coming to the table soon. And I think I'm going to end there. I have a lot of people to thank. I work with a great team, all of us here. And I want to thank Sue and the Transplant Ambassador Program for this fabulous invite tonight. But also Sue has helped me obviously with this and this genetic kidney website. So I'll take any questions there.
Okay, thank you, Derva. We can maybe take a couple of minutes here for a couple of questions that are in the chat, and then we'll move on to our panel. So We have a
Didn't
question
monitor the
here.
chat, so sorry.
Okay, we have a question here about a fellow who's asking about whether a biopsy is a good idea and what are the benefits of having a biopsy.
A biopsy is an excellent diagnostic tool, really good, and we've relied for years, decades on kidney biopsy to diagnose kidney disease. It really depends. I always go back to this. There's so many different types of kidney disease, and there's so many different ways you can present with kidney disease. It really takes there's no blanket kind of who should have it and who shouldn't have it. It really depends on the nitty-gritty of the detail on, how you present and what the urine looks like and what the blood tests look like. And for some people it's absolutely essential to have a kidney biopsy. And it gives the diagnosis, and it not only gives the diagnosis, but it gives, is there much scarring on the kidney, or, there's a multitude of good information you can get from a biopsy. When I'm talking about these patients who had kidney disease of unknown cause, unfortunately, they may have had a biopsy and it just didn't give the diagnosis, because sometimes the scarring is so advanced. I always say it's like having a scar on your hand that's old. You know that it's there, you have some damage, but what caused the scar in the first place? Was it maybe it's a bad analogy, but was it a knife, or you don't know because it's old. And it's the same with the kidneys. Sometimes the scarring is so advanced, it's hard to tell from the biopsy. And it's in these patients, and particularly these families, who ultimately genetic testing may be beneficial, where these other strategies have failed, if that makes sense.
Yeah, but Derval, I think that the first testing that you usually do is a blood test. Is that correct?
Blood tests, yeah, absolutely. Blood tests are your first round. You always start simple. The joy of the or the genetic testing from us is it's a blood test. It's a one blood test or a salival test usually. And yes, certainly a biopsy is a more invasive test, but it depends on you and your healthcare provider on whether you think that's beneficial. For me, as I said, I like genetic testing when it's appropriate and when it's indicated, because I don't require biopsies or anything like that. It's a blood test.
That's great. Thanks, Derval. Question, we have two other questions. Someone asking about the appropriateness of having genetic testing to help his children, so children will benefit from the findings. I think you talked a bit about that, but
I talked a bit about that. Yeah. So it's always hard before you go into the testing to know what the benefits will ultimately be until you know what the diagnosis is. But ultimately, generally in genetics, if you find the cause, it can be beneficial to know, well, how did I inherit it? Will I pass it down? Depending on how you carry the gene, you might have, higher risk to give it to your children or a lower risk to give it to your children. Sometimes changes in your gene just occur spontaneously, and it means that none of your siblings need to be tested. There's information on how the gene is carried that can be very beneficial to counsel individual family members. But ultimately, yes, I mean, we all share 50% of our DNA with mum and dad. So if mum and dad carry the gene, knowing that can be very beneficial for your children, because it allows them to have that information, and ultimately when they want to be tested, then they can make that informed decision on what's best for them.
okay, thanks. One last question. I see Fiona has her hand up, but Fiona, I'm going to ask you to put your question in the chat if it's okay. We'll come back to it just so we can move with our panel in a minute. But the last question, I think for now, is about CKD testing, which was not provided in Canada. So is the Canadian government covering those costs? I think is basically.
Yeah, the ministry, it's different provincially, so I can't give you the information outside of Ontario. But currently in Ontario, and in fairness, that's what we're doing up the guidelines for, to say what should be covered in province. But yes, there's panel testing, which is just a fancy name for a group of genes that we test. So there's a group of genes that cause, did someone say congenital anomalies of the kidney and urinary tract? And we can certainly test for that in Canada in people who look like that's their cause of kidney disease. So it really much depends on what your kidney disease looks like, and then you can pick out the testing that's most appropriate in that situation.
Okay, thanks, Derval. I just want to make sure we have time for our panel tonight. So we'll come back to some of these questions, and there are some general transplant questions that we can definitely squeeze in at the end. So if you put a question in the chat and we didn't get to it, we definitely will we'll get to it at the end. So thank you so much, Derv. I hope you can stick around for a little bit in case we have
Yeah, absolutely.
questions.
I
And,
have a question, Sue. I don't know, my screen changed.
okay, Amy.
Oh, okay, I can't see anything. Anyway, my name is Amy and I am a donor. The whole recording, the lecture went very well, and 20% I have retained in my brain. I'm going to watch it again once I get the recording. I'm going to pass it on to my daughter, who has received the kidney from me, and she just delivered a baby girl.
Oh,
Now,
congrats.
because my daughter is adopted from India and we have no family history of her, for the 2-year-old girl that she has, how can she look into testing the baby, in the future if she sees some kind of symptoms, or just to be safe before that happens?
We always recommend, as a general rule, to test the person who has the disease in front of you. Whoever has the kidney disease should be tested, and you find the change. And then if you find the change, you know the cause of kidney disease in that person. And then everybody else in the family who's at risk can then be counseled on, well, you might get kidney disease at 20 or 30 or 40 or 50, and then everybody can make an informed decision on, you know, do I want to know now? Do I want to know later? Based on what this particular type of kidney disease does. So my suggestion generally is I would test the person who has kidney disease, so the mom, and then you can make a much more informed decision when you have the exact information in front of you as to what the type of kidney disease is.
Okay.
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 Okay. Thank you, Dervla. So we're going to move then, and we'll come back to questions at the end into our panel. So first up, we have Robin and Leo. So I'm going to pass it on to Robin and Leo. We're going to share a little bit about their journey with genetic kidney disease. Let me just put the spotlight on them. If I can find them.
Great, thank you.
Yeah. Hi, everybody. My name is Leo. This is my wife, Robin.
Hello.
I was diagnosed with polycystic kidney disease approximately 20 years ago. We both live in London, and we've had all of our testing and transplant at the LHSC at University Hospital in London. And the diagnosis was really by accident. My mother was in a car accident, and as part of the treatment, they were just doing diagnostics on her to see where there might be some internal damage. And they determined that after an ultrasound that she has some cysts on her kidneys. And so then she was eventually diagnosed with polycystic kidney disease. So my sister and I have a twin sister. We were both tested shortly afterwards. And I drew the lucky straw, the unlucky straw, I guess you could say. So I had the gene for it. So I've had about a runway of 20 years preparing for what's going to happen, the decline in the kidney function and so forth. So I would have to say that I'm very fortunate in a way to have found out that many years ago and have testing, follow-ups, doctor's visits, nephrology visits to prepare me for what was coming. Part of the process also involved my mother, who had kidney disease prior to me. So she was, in one sense, my roadmap. She had, unfortunately, did not get a living donor. She obviously, I wasn't able to give one to her, and she would not accept one from my sister. And my sister, we don't know if she was a match or not, but she wouldn't even let her get tested. So we watched her kidney disease progress, and eventually she went on dialysis, and she had hemodialysis, and she would go to Westmount 3 days a week for approximately 2.5 to 3 hours. And at the time, she was older too. She was probably in her mid 60s, and it would wipe her out. She had been retired at that point as well, and we saw the toll that dialysis took on her. Then we watched her get a deceased donor, and she had a rare blood type, so she did actually get what they call a, I don't know if it's the official term, but it's an A grade kidney. Because of her age, they told her that you may not get highest quality kidney because we're going to give that to someone who's younger, who has much more longer life ahead of them. But due to her blood type, she was given a good quality kidney from a donor that no one else matched. So she is really doing well as far as her kidney function. Creatinine numbers are really, really low, and she doesn't have to worry about it anymore. So that's a success story in that sense. So we watched her, and I understood what she went through, and I knew that that would be my path as well. But knowing that there was a runway for me to get ready for transplant, my wife and we discussed, and she volunteered to get tested. So my wife Robin was actually the donor, and we were a match, which was very, very lucky. And I know the stats on that. It's not super common, but it does happen. So I was very, very fortunate to have a donor in the wing waiting, so we could schedule our surgery when it was, I wouldn't say convenient, but as convenient as it could be. We had our surgery at University Hospital in London, September 9th of 2020, so it was right in the heart of COVID. And a lot of the restrictions and protocols and lockdowns made things a little bit more difficult, but we persevered. And we knew that after coming out from surgery, we both would need time to recover. So Robin's parents came all the way from the East Coast, and they stayed with us for about 6 weeks. So about 2 weeks of that was before surgery because they had to go through quarantine. And if you remember that, it seems such a long time ago, but we all went through it. And they helped us out. So after we came back from surgery, we were in hospital for about 8 days each. We came back, and we really were restricted on what activities we could do and how much we could lift. So we had prepared a whole bunch of meals. And of course, I still had to go into the hospital once a week for testing post transplant. So they were very, very instrumental in our recovery. And it was overall, I would say it was as good a process, a good an experience as it could have been. The hospital staff, and the transplant unit were phenomenal. The nephrology teams I've worked with prior to and post were phenomenal as well. Just a bit of an update. What's happened since then? So probably just over a year ago, they found out that my creatinine levels had started to increase again. So after some testing and a couple of biopsies, it turns out that I have a virus attacking my kidney. It's called a BK virus, and it is fortunately decreasing my kidney function at this point. So we've exhausted all the measurements or all the different medical tools in the arsenal. And so right now we're a wait and see approach where my creatinine is holding steady at about 299. That seems to be my new normal. But after surgery, it was about on the low point, about 109. I feel okay. I still have a little bit of fatigue from time to time, but we're working through it. You want to add anything?
Yeah, so back to with Leo and the polycystic kidney disease, as you know, his wife, and seeing and knowing that kind of ahead of time was, I found very beneficial for us. Leo was monitored closely with his nephrologist. We knew kind of what the path was going to, like our future, how that was going to unfold. So basically, either Leo was going to go on dialysis and then wait for transplant, or we could see about finding a living donor. So watching Leo's mom go through dialysis and then getting a deceased donor transplant was an eye-opener for me. So I didn't want Leo to go through dialysis. Dialysis is wonderful, but it does take a lot of energy out of you. They compare it to running a marathon. So My mother-in-law was pretty exhausted after each dialysis run. So Leo and I have the same blood type. So I said to him, it's like, why don't I get tested and go from there? So I reached out to the living donor clinic here in London and started the process. So for me, it took about 10 months of testing, and I was thrilled to be a match for Leo. So, and surgery was good, and we're doing pretty well right now.
That's our story.
That's our story.
Thank you. So I think that you mentioned that you had a preemptive transplant
Correct.
prior to dialysis. And so obviously that being proactive and knowing that you wanted to go this route allowed you to avoid dialysis entirely, which was
Yes.
Yes.
Yes. Very
Great.
fortunate.
a great thing. Okay, well, thank you so much for sharing your story. And we really appreciate it as always. I'm going to go next to Michael Ann, and just a quick time check. I think we have 3 to 4 minutes for the next 5 speakers, just to allow time for questions. Over to you, Michael Ann.
Can you hear me now? Yes, perfect.
Yeah.
So I'm Michael Ann, and I am a living donor. My genetic story goes back to the time that my daughter was born. So genetic testing might have changed the way that she was born. I'm struck by Dr. Connaughton saying it takes sometimes 13 and a half years for diagnosis. And I can tell you within the first week of my daughter's life that she was diagnosed with what's called autosomal recessive polycystic kidney disease, which means that 1 out of 70 met 1 out of 70, and there was a 1 in 4 chance, which means that 1 out of 20,000 children are born with polycystic kidney disease in the autosomal recessive. My daughter was one of them. We were so very fortunate in a small Northern Ontario hospital to have a doctor on loan from Shriners Hospital in Montreal who put all of her symptoms together, the pneumothorax, the lack of amniotic fluid, the high blood pressure in a newborn, and be able to say, I think it's a kidney disease. And he was actually able to pinpoint it, all based on the anecdotal evidence. Later, we were able to get genetic counseling, and we're told that 1 in 4 of any future children, we ran the risk for 1 in 4 of any future children. So we had that anecdotal information, but we didn't have the actual genetic coding. The coding for my daughter's kidney disease wasn't discovered until 2002. So fast forward to 2018, and she had a preemptive kidney transplant on December 6th. We did our workups through the University Health Network in Toronto, and we had the transplant and the donation in Toronto, a couple of operating rooms apart. I now understand that I can have, or that donors can have, the workups in North Bay, which is 4 hours north of Toronto. That would have made a big difference. So genetic counseling for me would have prevented, not genetic counseling, but having that genetic connection might have prevented a really traumatic birth experience. We didn't know whether she was going to survive or not. And in the first weeks and first days of her life, we were told that 70–80% of children born in this way weren't going to survive or didn't survive. And then we were told if she makes it beyond a year, there's a 50 or 60%. And then we were given, the longer she lived, the higher the percentage went. So 38 years later, she had her transplant. And now I can tell you part of her story is that she's thinking about having children of her own. And so that's a huge relief for her to have the genetic testing done and to be able to, even though it's extraordinarily rare that she would ever meet somebody with the same genetic mutation, it's still reassuring for her as she moves into having children of her own, to know that that they can screen that out if necessary. From a personal perspective, I can also tell you that I have a dad who's currently on dialysis, and I have two uncles who both had chronic kidney disorder. We think that it's due to other factors such as medications for mental health or diabetes. None of us have been tested for genetic for to see if there's a genetic. And I'm sitting here today thinking, I have one kidney left. It might be a really good idea if I went through genetic testing. I live my life on a daily basis as though I have kidney disease. It's how I raised my daughter, and it's now how I live my life. So low salt, lots of exercise, daily quota of water, and just being really careful with what I put into my body. So that would be my, my greatest advice to the general population and to anybody who's even thinking that they might have a kidney disorder, is to take really good care of yourself. That's one of the things that we can do for ourselves. Genetic testing is wonderful. Knowing is preparing. Knowing is understanding how to get treatment. It's treating our bodies well, but ultimately the decision is ours. Back to you, Sue.
Thank you, Michael Ann. That's really, really interesting, and we appreciate you sharing that story with us. Quite a journey that your family's been on as well. We're going to go next to Barb. Over to you, Barb. Oh, Barb, you're on mute. Yeah.
There we go. I was just going to say before I start, Leo and Robin, boy, much of my experience, my family's experience, I see so many similarities. And Michael Ann, what an amazing story, that you shared. So, again, my name is Barb, and from my land acknowledgement, I live in Brantford. I donated my kidney in January of 2018 at St. Joseph's Hospital in Hamilton, where we both received our transplant workup. So my story will be a little different than others because a genetic link for my husband's kidney disease has never been confirmed, even though it was highly suspected. So my husband was diagnosed with focal segmental glomerular sclerosis over 30 years ago, shortly after we were married. So he was fairly young. I think he was in his late 20s, early 30s. His mother also had chronic kidney disease. She was on dialysis, and she received a deceased donor transplant in the early 1990s. She never had a biopsy due to the advanced scarring of her kidney when her kidney failure was diagnosed. But after her death, years later, and some years later after that, we learned that a few family members on my husband's mother's side in Italy also had kidney disease, and his cousin in Italy had just had a kidney transplant. So it was that information that led his nephrologist, so this is pre-transplant for my husband, to investigate further about possible genetic kidney disease. He wondered whether there was some form of Allports, knowing my husband's biopsy had diagnosed FSGS as his cause of his kidney failure. But it was really important for us to know, too, if our son could possibly develop kidney failure in his lifetime, as well as to provide answers to the rest of his immediate family about kidney risk. However, there were some barriers to connecting the dots. It was very difficult to obtain medical history from Italy, along with the fact that some of his family members had passed away. We did receive some medical information, but it was really difficult to translate, to sort of compare sort of medical terms. So anyways, at that time, his nephrologist decided to send blood work to the US at the time for testing. And what we were told were the results didn't identify a genetic diagnosis. The only reassurance we had at the time was being told that if there was a genetic link, it was most likely passed down on the maternal side and our son would never be affected. And that's really where our genetic investigation ended years ago. So fast forward, the decision to donate my kidney was an easy one. Similar to Robin, my mother-in-law had gone through hemodialysis. We saw what the future was like for my husband, and if there was a possibility I could be a donor, it was a no-brainer for me. So we were fortunate to have a doctor who spoke openly about the eventual need for kidney transplant, even if it was years away. And he also prepared me for the possibility that I could be my husband's donor. So we knew that we had the same blood type. And thankfully, when the time came where he needed the transplant, we were, I'm going to say, the perfect match. I keep telling him we were perfect all these years, 36 years later. So 6 years later, my little kidney really does continue to do its job. And I have to say, I think his last creatinine level was better than mine. So this is where my story picks back up. Even though we were told years ago not to worry about my son, who's now 25, about inheriting kidney disease, it has always worried us. We've always held this reservation that perhaps that comment made by the doctor wasn't true. So after hearing Dr. Connaughton speak, my message to everyone is, even if genetic testing doesn't confirm a genetic diagnosis, testing can be repeated every few years. Genes that were perhaps not identifiable with previous testing can now provide the answers you need for you and your family. So that's my story.
Thanks, Barb. That is such a great story, and thank you for reiterating that like ongoing testing is really needed if they don't find the answer. I don't know, Dr. Connaughton, if you want to make a comment on that.
Yes, I always say, yeah, that's certainly true. And the guidelines now currently is, if you suspect, like if you meet the criteria, you have a family history, you meet the criteria that you should have genetic kidney disease or you possibly have it, you should repeat investigations every 18 months to 36 months. And the reason being is, when I started off in kidney genetics several years ago, there was 200 genes. And now I last said there was 600 genes. And really there's probably 800 genes. You know what I mean? There's new genes every time. So if you had testing done of, you know, genes that haven't been discovered, there's no way for you to find it. So it's not a one and done type situation, particularly if you have a high risk. And by that, multiple family members affected. So there's always more to be discovered, and there's always new information being added to the system that can help kind of provide those answers. Great stories, though. Thank you for sharing.
Thank you, Darla. Okay, we'll go next over to you, Greg.
Okay, yeah, quickly, because we're running out of time here. A lot of my story is similar to the other panelists. I received a liver and kidney transplant, double transplant, in 2016 here in London, Ontario, where I live. Very fortunate to live right beside one of the best transplant centers in the world, likely. My father actually died of polycystic kidney disease in 1958 when I was 4 years old. And I was diagnosed when I was 25 years old. And at that point, the nephrologist says, well, you're probably going to need a kidney transplant in 3 to 5 years. And so it was very good that the idea of transplant was introduced in our very first conversation with my nephrologist. And he said, yeah, 3 to 5 years. He says, not really anything to worry about. He said, it's a little bit more involved than changing the engine in a Buick, but not much. And that points to another real advantage of having an early diagnosis and knowing is that, again, they said 3 to 5 years with proper management of my kidney condition and a really good relationship with my care team. Instead of getting 3 to 5 years, we got 35 years out of my kidneys. And I didn't have my transplant until I was 61 years old. That allowed a lot of time for planning. So the idea that rather than being a crisis that people crash into kidney failure, mine was just always background noise. It was always in the background. Dad's got this kidney thing, and he's going to get a transplant one day, and let's just get on with life. as far as family planning, they said, yeah, don't, go ahead, have kids. We didn't have the genetic testing, way back in the 90s and everything, but they said, yeah, it's not the worst thing in the world. Go on and have kids. Now my kids are in their 30s, and they have no signs of kidney disease. The other thing that we were able to do, though, through that 35 years is constantly monitor my situation, keep myself healthy in all other regards too, diet, blood pressure, all that type of thing. And so by the time I did need a transplant, it wasn't a panic. My wife, again, there's a common thread here of wives being donors for their husbands. My wife immediately agreed to get tested. She was a match. It was really cool that after 30 years of marriage, we had clinical evidence that we were compatible. So people said it wouldn't last. Well, I actually did. But then I was found to have cysts on my liver as well, and they were enormous, and the liver was failing, and it was making life difficult for all the other organs. And so at the very last minute, the preemptive transplant was off the table. My wife could not be a donor. She was crushed. I had to go on dialysis for 6 months. And that's no way to live. Went on dialysis for 6 months, and then finally got a very good pair of organs. And what that's done for my life is absolutely amazing. I was always very active in, bicycle racing, all that sort of thing. But for the last 10 years, I really wasn't able to do anything. Since the transplant, my numbers are all good. I've competed in the Canadian Transplant Games and the World Transplant Games, finished in the medals even. And last summer, we did a ride through the Alps and the Dolomites with 70 other riders. Half of us were organ transplant recipients, and the other half were all transplant medical people. So yeah, the bottom line is, yeah, it really is worthwhile to know about it. You can plan your life. You can also plan your career. I mean, I was telling Sue that every company that I've ever worked for has wanted to transfer me to the U.S. And knowing that there was a kidney transplant in my future, I did not want to have anything to do with the American healthcare system. And so I stayed in Canada. And when my American colleagues asked me, oh my God, what did that kidney transplant cost? I tell them, well, I had to pay for parking. So that's all, Sue.
Thank you, Greg. Thank you so much. Great story. Just again, quick check on time. We do want to leave room for questions. So we have 2 speakers left, Dom and Alex. So Dom, I'm going to try to ask you to squeeze your story into 3 minutes if you can.
Yep.
And try to provide some sage advice to some of our folks in the.
Okay, I'll make it as quick as I possibly can.
Thank you.
First of all, I have polycystic kidneys. The big thing about me is that both my parents had polycystic kidneys. So we were actually with research back in the 80s. We went to Denver, our whole family at the time, to do some research because at that time they had polycystic 2 kidney gene, but not the polycystic 1 kidney disease gene. And I'm hoping that my family was some input to try and get the PKD1 gene. So anyways, we went to Denver, Colorado for that. My mom ended up with a kidney transplant back in 76, I would believe. At that time, she was only in her 40s, and she lived to be 67. So she had her transplant for 24 years. At that time, was considered experimental. My youngest sister died of breast cancer at 26, so she had PKD, but we don't know how that would have gone. My older sister had a breast cancer in her 50s or late 40s, beat that, went on dialysis for PKD, was doing dialysis and then ended up with a Ewing sarcoma. I can tell you that my sister had a living donor from her sister-in-law. Unfortunately, that kidney was rejected. And so what happened is I think everything was fine, but I shouldn't say it was rejected. What happened was that I think one of the anti-rejection drugs that she had an allergic reaction to, and that caused the whole thing to tumble at that time. So anyways, My dad was started dialysis when he was 69, and he lived for 17 years after that. He actually passed away when his fistula bled out when I wasn't home. So that was very tragic as well. But he was 86 when he passed away. I had a kidney transplant just over 2 years ago. I was on dialysis for over 5.5 years. Because I knew of all the issues with dialysis, I took my dialysis for all those years. Um, it really with me, I ended up doing home hemodialysis, and rather doing 9 to 12 hours a week, I did 28 hours of dialysis a week. And when I started dialysis, I was at very low kidney function. I was down to 5%. I worked full time through all that. I was union president, took care of 1,300 people, very demanding job. Actually, when I was down to 5% kidney function, I built a garage in the back, did everything myself. I had the roof shingled before I started dialysis. I finished the drywall and the wiring and all that stuff after being on dialysis and working and doing all that dialysis. So, I mean, you could do whatever you want at the end of the day. And I just talk, I know everybody else talked about it. Me knowing that I had kidney disease in my 20s was difficult for me. I would say that the anxiety of, raising a young family, there was health issues in my family at the time. My wife had some health issues as well. And I would say that it was really stressful for me to know that I had polycystic kidneys. Looking back, if I can talk to myself, I would say, listen, you know what? Don't worry about it. Everything's going to be fine. The stress of it was worse than actually going through it. When I first sat in a dialysis chair, it felt normal for me because I've seen so many members of my family on dialysis. I could already envision how the needles would feel and all of that. And I knew exactly, how the cramps would feel, even though I'd never had them before. But anyways, I did very well with all that. Because I was in such great shape with doing so much dialysis, I did have my kidney transplant in Toronto, and within 3 weeks, I was walking 10 miles a day down in Toronto. My kidney function is around 100. 113 is probably the highest it's been, once when I've recovered. And so anyways, I'm doing well still, and I just hope to continue on. I am retired now from being a union president, but because I had a kidney transplant, and I should also mention I've been restoring cars while doing all that as well. So I'm still doing the car restoration thing, and I was elected to city council, in the last election. I can't even, that would have been 2024. And I'm now, no, we're in 2024 now. It's 2022 when I had the election, and I'm in the middle of a 4-year term. So none of this would be possible without the kidney transplant. And I've spoken enough, but I tried to cram in as much as I can, as quickly as I can. And well, I'm sure we'll discuss things at a different time. So thank you very much. And I'm still looking for my vest. I don't know what it is. I'm sorry. Okay, so that's it. We'll go on to the next person.
Thank you, Dom. Between you and Greg, I think we don't want to give the impression that you have to be like a superstar energizer bunny to be able to have a successful outcome, even though you guys seem to really be able to outdo most of us who are on dialysis. But good for you. That's I think optimism and your attitude has obviously gone a long way. Okay, Al, I hate to it says 5 minutes left in our meeting. I hope it's not going to get cut off. I don't think it will, but I don't know if there's something you can do on your end. We're going to go over to you, Alex. Maybe you can just emphasize some of the points of your story that haven't kind of come up, if you can.
Yeah, sure. So I'll be happy to. I'll try to do it really quick. My name is Alex. I had a preemptive kidney transplant in London in 2017 from an unrelated living donor. My donor needed to be unrelated because we knew that my kidney disease was genetic, though it was undiagnosed at that time. And so my close family members, including my 2 sisters, could not be considered as donors for me. And, I've really been so grateful to share my transplant story many times. but I would like to share as quickly as I can some.
Alex, sorry, we're not seeing you on camera. Are you on camera?
I am on camera.
Okay, I don't see. Okay.
I can see her.
I think it's because we're both on the top teams. So I'll just continue really quickly. So I just tonight would just very quickly like to share a little bit of closer personal history with you. So I knew my beloved Papa, who was my mom's father, as a loving, fun, active grandfather and my biggest cheerleader and role model. Though Mom recalled to us many times her memory of her dad on a big, scary machine, a 1970s home dialysis machine before his transplant. And that was very hard for me to imagine that same man as the Papa I knew throughout my life. And, he would often take me up long drives up Blue Mountain in Collingwood and tell me stories of his own father, who was a war veteran and passed away during his own transplant, but as a result of a sepsis infection. Years later, in 2010, I saw my incredible mom through kidney failure, dialysis, and a kidney transplant. And then, in August 2014, life was good for me. I was 27 years old, had my entire future ahead of me, and had just returned from what I expected to be a regular annual checkup with my family doctor. My kidney function was regularly checked at those appointments just as a result of my family history. And it was that appointment my doctor told me that my creatinine was high normal, and that could mean something was happening with my kidney function. I always knew this was possible, but had hoped and prayed I'd be on the other side of it. But I was hearing the words then that I dreaded to hear, that I have the lucky gene and that my kidneys would fail. Over the next 3 years, my kidneys declined. I felt sicker and weaker, but it was Mom's strength and guidance that helped me to resist my strongest desire to bury my head in the sand. She told me, Alex, you will have a transplant before you go on dialysis. We will make it happen and you'll be in that 2%. She often pushed me, sometimes uncomfortably, to amplify that to my medical team. And I told them, I think every appointment that I wanted a preemptive transplant, and that I wanted to be a mom. And through that difficult process, and perhaps through advocating for myself strongly, I was questioned many times, and even questioned myself, considering that the only thing we really knew at that point was that we knew any future children of mine would have a 50-50 chance of inheriting kidney failure from me. One particularly hard day of appointments with Mom, of course, as she was usually always with me. I asked her the question that was really flooding my mind, and that was, would I still be here if you knew that one day my kidneys would fail? And Mom answered without hesitation, of course you would. You'll have a full and happy life despite your kidney failure. And just as Mom promised, I did get my preemptive transplant on a beautiful July day in 2017. On a snowy night in March 2019, I welcomed my first baby. And then 13 months later, on a beautiful May morning, I welcomed my second baby. Soon after, we met an incredible doctor by the name of Dervla Connaughton at the transplant outpatient clinic at LHSC, and it was Dervla's guidance and support and expertise that led us down that road of genetic testing. And finally, in 2020, our genetic disease was finally identified as MUC1. And MUC1 is rare, only diagnosed in about 200 families in the world. It affects the protein of the kidneys, as you saw in Dervla's presentation, causing abnormal protein to build up in the kidneys over time and ultimately cause adult onset kidney failure. So what does this mean for me and my family? Well, because we know the cause of this diagnosis, my two babies, my boys, will now have the advantage of that clinical research. They will have access to the advances in treatment and so much more potential to treat this diagnosis over time. Though my children will not be tested until they are of appropriate age to consent. They're 3 and 4 now, so that's a long time away. we have the knowledge, and we have the knowledge going forward with diagnosis that I have no doubt will change their outcome, and may even present alternative treatments to transplant should they need them. And so I just want to really drive home this message that there's no value that I can put on the power of knowledge that genetic research provides. Despite that desire I had as a young woman to bury my head in the sand, I'm so incredibly grateful that they have this knowledge and our family has this knowledge, and what it means for them and their future. And Dr. Connaughton, can't thank you enough for your guidance, and see you tomorrow in Transplant Clinic. Did I do that quick enough, Mom? I hope so.
Yeah, no, that was great. Okay, I don't know if you spotlighted yourself or not, but you can unspotlight, and hopefully we can spend just a few extra minutes answering any questions in the chat. I know we're at time. And if anyone has any questions that you want to ask Dr. Connaughton in the next couple of minutes, please just put up your hand. So just to go back up, sorry, there was a question about, this was more of a general transplant question, I think, Dr. Connaughton. I don't know, you might be the best to answer it. About blood group B, positive being the hardest blood type to find a kidney donor match. This patient is looking for advice about finding a donor, and about what is the success rate of this type of transplant from I guess, different blood group?
Yeah.
I
mean, usually, yes, you need to be a blood group match to get I'm echoing there, sorry. A blood group match, but it doesn't necessarily need to be. I would always say, just if you have donors come forward, just get them tested, because there's other options out there as well. If you're not a blood group match, or even not a match, there's the paired kidney exchange. So there's multiple options for donation, that you don't necessarily just need to be a blood group match. We do have options to cross blood groups as well, so it's not like you need to be a perfect match. The hardest one, probably because there's most people, is for recipients to be blood group O. So but again, not something that should ever prohibit you from going forward with transplantation.
Thanks, Dr. Connaughton. So we talked a little bit about how the genetic kidney test is done. You mentioned primarily by saliva test.
Yeah, saliva, or you can do it by blood. So the purple vials of blood, if you ever go to the clinic and you get the purple ones, it's just one of those vials of blood. You extract the DNA, and DNA can last for years and years and years. The only reason you generally need a second test is if the actual volume, the amount, so let's say you send a blood test here and send it there, then you don't have enough physical volume left. But it's very easy. We don't extract DNA from spit as much. We do it for more research-based testing, because some labs don't extract spit, but it can be done. And certainly from our kiddos, we do spit or buccal swabs. So it's easy to get DNA. You don't need any tissue, or you don't need any biopsies or anything like that.
Thank you. So this person is asking if their annual blood test is the same as getting a genetic test.
No, definitely not. The genetic testing would be very different type of testing. Again, whoever is ordering your testing would generally chat to you about it in advance, would talk about the type of testing they're doing, what that testing will show, what that testing won't show. And it's usually done in a dedicated, kidney clinic, or a kidney genetics clinic, or a genetics clinic.
Yes. And is genetic testing is the blood test that you're checking albumin? I don't think so, but
no, it's just blood. It's usually blood. It's called the EDTA blood. That's just the tube that we put it in, and it's as I said, when you get, it's usually the one that your blood count, your hemoglobin or your cell count is checked on. That's the similar test. It has to be ordered separately, but it is the same vial that you would use to check your blood count.
Okay, and someone asking about someone who has scleroderma and vasculitis, and is in stage 4 kidney disease. Would those autoimmune diseases affect them from getting a successful kidney transplant?
again, those particular diseases shouldn't. Each person though has to be assessed individually. It's very hard to give blanket statements just about general things, because you know some patients can have other diseases with it as well. But there's very few diseases, if any, that you would say you couldn't have a transplant in. You know, it would be very rare. It's more just the whole collection of how fit you are and everything else. That, you know, it's each individual person assessed individually. So it's hard to say just based on that, but I understand. Yeah.
So look into it, I think, is the
I would
bottom
look
line.
into it. That's the thing. I would say each person should look in individually as their own case, and everybody rightly should be assessed individually. You know, because everyone's an individual and everyone's different.
Yes, exactly. The last question in the chat was a gentleman looking for a kidney donor, and you might not be able to find it in this group since we're all transplant recipients, donors. But we definitely, we have a platform on our website you can check out, and you can certainly reach out to any of us afterward, or check out our ambassador directory, and we're happy to give you some tips on that. So I think that really puts us at time. I didn't see anybody's hand up, I don't think. And thank Dr. Connaughton for her time tonight and providing some excellent information, and all of our panelists for sharing some great stories with us. So feel free to reach out to us. We'll be happy to help at any point. Dr. Connaughton put up her her website again, which is the kidneygeneticsclinic.ca, and even if London's not the place where you'll be going, I'm sure her people can advise on a clinic in your area. So thanks again to everyone. Thanks to all of you who joined us tonight. We really hope you enjoyed the night as much as we did. Good night for now.
Thank you so much.